Hello everyone and welcome to our module on genital embryology. In this video we're going to talk about the development of the genital system. So first of all, you should be aware that the chromosomal sex of a fetus is determined at fertilization. A fetus with two X chromosomes is female and a fetus with an X and Y chromosome is male. Now later, the fetus will develop gonads, which are the ovaries and testes, and internal and external genitalia. And if the baby develops normally, the gonads and genitalia will match the chromosomal sex. In this video, we're going to talk about how the genital system develops, and I strongly recommend to you that you think about development of the gonads separately from the internal genitalia and the internal genitalia separate from the external genitalia. Basically, all three of these elements of the genital system have their own developmental processes, and we're going to go through them one at a time in this video. We'll start by talking about the development of the gonads. There are structures in the embryo called gonadal ridges that form at about 7 weeks. They are derived from mesenchyme, which is embryonic connective tissue made up mostly of mesoderm. The germ cells, which will eventually develop into sperms and eggs, are derived from epiblast cells. The epiblast is one of the two layers of the bilaminar disc in early embryo development. These germ cells will invade the gonadal ridges, and if they don't reach the ridges, the gonads will never develop. So a key element is that germ cells which come from the epiblast have to migrate and invade the gonadal ridges. And initially, the male and female gonads in the embryo are identical. This is called the indifferent gonad. It is not yet a testis or an ovary. If the fetus has a Y chromosome, then it will have the SRY gene, which is found on the Y chromosome. And this gene on the Y chromosome is what makes male babies male. It codes for the testis determining factor, which leads to the formation of Sertoli and Leydig cells. Once these cells form, the Leydig cells begin producing testosterone, and testosterone leads to male development. There are structures called medullary or testis cords which will begin to form once testosterone is present, and they will expand out of the testis and connect to the genital ducts, which we'll talk about later. So the key point here is that you must have the SRY gene on the Y chromosome to form testes. If you do not have this gene, then ovaries will form. And that's what happens in the female. The female does not have the SRY gene, so the medullary cords we just discussed will regress. A different type of cords called cortical cords will develop. They will form clusters in the gonad and surround the germ cells, and then the oogonia and follicular cells will form into primordial follicles inside of the ovary. So now we've talked about how the developing embryo begins with two indifferent gonads, and if the embryo has a Y chromosome and the SRY gene, then testes will develop. If the embryo does not have a Y chromosome, then ovaries will develop. Now we have to talk about how we develop the internal genitalia that hook up to these gonads. Are we going to develop an epididymis and a vas deferens like in the male, or are we going to develop fallopian tubes like in the female? And these internal structures like the vas deferens and the fallopian tubes develop from what's known as the genital ducts. These are two pairs of structures called the genital ducts that are found in the embryo. The duct that can develop into male structures is called the mesonephric or Wolffian duct, and the duct that can develop into female structures is called the paramesonephric or Mullerian duct. And basically what's going to happen is one of these ducts is going to persist and the other one is going to go away depending on whether the child develops into a male or female. And just an aside here, in the renal video on renal embryology, I talked about the mesonephros. This is the interim kidney in the first trimester. It eventually goes away and does not persist into the adult. However, it has an associated duct called the mesonephric duct, and that's where this duct gets its name. It also has another duct that is near the mesonephric duct, and that is called the paramesonephric duct, which is how the Mullerian duct gets its name. So as I mentioned before, the two genital ducts will develop into the internal genital tracts. In the male, they will form the epididymis, the vas deferens, and the seminal vesicles. In the female, they will form the fallopian tubes and the uterus and the upper vagina. So let's talk about how the genital ducts develop in the male. Obviously in the male, you want the Mullerian ducts to go away because those lead to development of female structures. The way this happens is the Sertoli cells release a substance called Mullerian inhibitory factor. It suppresses development of the paramesonephric or Mullerian ducts, and they will eventually go away, but for a small remnant in the male called the appendix testis. This is a little bit of tissue at the upper testis. It's shown here in this drawing at the bottom right side of the screen. In addition, in the male, the Leydig cells will secrete androgens, and these will drive development of the mesonephric ducts into male structures. And in the male, the mesonephric duct will elongate to form several key internal structures. These include the epididymis, the ductus deferens, the seminal vesicles, and the ejaculatory ducts. And in the next few slides, I'll go through each of these structures so it's clear in your mind what derives from the mesonephric ducts. So the epididymis is a duct behind the testis. It's shown here in this drawing at the bottom of the screen. It transports sperm from the seminiferous tubules to the vas deferens. The ductus deferens or vas deferens is another duct that transports sperm from the epididymis to the ejaculatory ducts. It's shown here as this larger duct in this drawing at the bottom of the screen. The seminal vesicles are glands that sit behind the bladder, and they secrete about 75% of the fluid in semen. The majority of the fluid in semen comes from the seminal vesicles. They connect with the ejaculatory ducts so that they can transport the fluid into the ejaculatory ducts. And those ducts collect sperm and also fluid from the seminal vesicles and pass it through the prostate. Some more of the fluid in semen comes from the prostate, and that connects to the urethra, and therefore the semen can be released out of the urethra. And here's a drawing of the internal genitalia like you can find in your textbooks. This is the testis right here, and then I'll highlight all the structures that come from the mesonephric duct. That includes the epididymis here, the vas deferens here, the seminal vesicle, this gland which sits behind the bladder, and also the ejaculatory duct which connects the seminal vesicle to the urethra. Now let's talk about development of the internal genitalia in the female. In the female, the paramesonephric ducts will form the internal female structures. This occurs because there is no Müllerian inhibitory factor or androgens in the female. Therefore, the paramesonephric ducts persist, and in the absence of androgens, the mesonephric ducts do not develop. And therefore, in the female, the paramesonephric ducts develop into the fallopian tubes, the uterus, and the upper two-thirds of the vagina. And here's a drawing of the female genitalia. I'll highlight the Müllerian structures. This is the ovary. The fallopian tube is a Müllerian structure, so is the uterus, and so is the upper portion of the vagina. In females, a Gartner's duct is a structure that is a remnant of the Wolffian or mesonephric duct that persists in females. They're found on the vaginal walls. Sometimes they form a cyst, which can occasionally become painful and require surgical removal. And here's a picture to just kind of pull it all together. So the embryo begins with a bipotential gonad, and both the Wolffian and Müllerian ducts are present. If the SRY gene is present in the embryo, then testosterone will be synthesized, and Müllerian inhibitory factor, sometimes called Müllerian inhibitory substance, is also secreted. This will drive formation of all the male structures. If these two factors are missing, in other words, if the baby is female and there's no testosterone or Müllerian inhibitory factor, then the female internal structures will develop. Now, not all the internal genitalia come from the genital ducts. Some of the internal genitalia derive from another embryologic structure called the urogenital sinus. In the embryo, there is a structure called the cloaca, which is part of the gut tube. I'll show you a picture of this in a minute. And it divides and forms the urogenital sinus and the anal canal. And the urogenital sinus goes on to develop into some of the male and female internal structures. Here's a drawing I used to discuss the formation of the gut in the GI video on GI embryology, and I just want to point out that the cloaca is this turn in the gut tube down here at the bottom. It will connect to the exterior of the embryo and form a hole. It will then divide down the middle. The bottom portion will become the anus, which connects to the GI tract. The top portion will be a blind-ended cavity. That's called a sinus, and that will be called the urogenital sinus, which will give rise to some of the internal genitalia. It will also persist as a hole on the outside, and that portion of the urogenital sinus will give rise to some of the external genitalia, which we'll talk about later. In males, the upper portion of the urogenital sinus forms the bladder. The pelvic or middle portion forms the prostate and the prostatic urethra, and then there's another portion called the phallic portion, which forms the penile urethra. In females, the upper portion of the urogenital sinus also forms the bladder, so you can just remember that the bladder always comes from the urogenital sinus, no matter whether it's a male or female child. The pelvic portion of the urogenital sinus in females, however, forms the inferior vagina and connects with the paramesonephric or Müllerian ducts. So in females, the inferior vagina comes from the urogenital sinus, and the superior vagina comes from the Müllerian ducts. One of the key structures that derives from the Mullerian ducts in females is the uterus, and in order for the uterus to form, both the left and the right Mullerian duct must come together normally and fuse to form the uterus in the middle. Many times this process doesn't happen normally, and this leads to anomalies in uterine development. So-called lateral fusion defects are the most common type of uterine anomaly. This is when the two sides of the uterus don't come together normally, because remember, the uterus has to come from both Mullerian ducts coming together normally. And the problem this can create for women is infertility and pregnancy loss. If the uterus doesn't have a normal shape, it can be difficult for the embryo to implant in the wall of the uterus. The most common uterine anomaly is called a septate uterus. It gets its name because in this condition there's a septum that divides the uterus into two endometrial cavities. Basically, a normal uterus is supposed to look something like this with a cavity in the middle. In a septate uterus, what you have is a septum dividing the uterus into two cavities like this. This occurs because this septum in the middle is supposed to be resorbed during development. It's a remnant of the two Mullerian ducts, and if it's not resorbed, it leaves this septum down the middle. And this can potentially be treated with a surgery called septoplasty, where they cut out the septum. And then there are a number of other less common uterine anomalies. In a bicornuate uterus, the fundus is indented due to partial fusion of the Mullerian ducts. Basically, in this condition, the uterus looks something like this, with one pathway going over here to one fallopian tube and another pathway going over here to another fallopian tube. It's not that there's a septum down the middle like we talked about in a septate uterus, it's that the uterus itself is indented. In a unicornuate uterus, the uterus connects only to one ovary and the other ovary is not connected to the uterus at all. And then finally, there's a condition called uterine didelphys, or double uterus, where the Mullerian ducts fail to fuse whatsoever, and there are basically two separate uterus structures. So there's one on one side that goes over to one fallopian tube, another on the other side, and they're not connected at all by any tissue in the middle. And the way these conditions are usually diagnosed is by what's known as hysterosalpingography. This is where you inject dye into the uterus and you see the shape of the uterine cavity. That's what's shown here on the screen. So now we've talked about the gonads and we've talked about the internal genitalia. All that remains is to discuss the development of the external genitalia. And just like the gonads, the external genitalia begin with an indifferent stage where they look the same whether it's a male or female baby. In this indifferent stage, there are four key structures that will develop into the external genitalia. First of all, there is an opening called the urogenital sinus. We talked about this before. This is the opening to that sinus that comes from the cloaca when it divides to form the anus, which will be somewhere down here, and another opening up above, which is the urogenital sinus. Around the urogenital sinus, there are folds of tissue called the urogenital folds that also come from the cloaca. Above the sinus, there's a small nodule of tissue, which is called the genital tubercle, and then surrounding the urogenital folds, there are swellings called labiosacral or genital swellings. Basically, what's going to happen is in the male, the genital tubercle is going to elongate into the penis, and the urogenital sinus is going to close. In the female, the urogenital sinus is going to remain as the opening to the vagina, and the genital tubercle will become the clitoris. So here's what happens in the male. The genital tubercle elongates and forms the phallus, which is just another word for penis. Those folds of tissue called the urogenital folds will close and form the penile urethra. And then the urogenital sinus will go on to form glands. Remember that that sinus is a cavity that goes inside the embryo. The opening to the cavity will be closed when the folds come together and form the penile urethra. But that cavity that goes inside of the embryo will form glands inside the embryo. And in the male, this includes the prostate and also the bulbourethral glands of Cowper, which both contribute some of the fluid to ejaculate. And then finally, those labial sacral swellings, which are those swellings of tissue on the outside of the indifferent gonad, will ultimately go on to form the scrotum. In the male, the urethral folds, which are located on the outside of that opening, the urogenital sinus, have to come together and seal in order to form the underside of the penis. If they don't come together normally, an opening can be left, and this is called hypospadia. This is a congenital anomaly of the male urethra. It's a ventral opening of the urethra, meaning an opening of the urethra on the underside of the penis. It's caused by failure of the urethral folds to completely close, and these are some examples of hypospadia at the bottom of the screen here. And in about 10% of cases, when a male child is born with hypospadia, there is also cryptorchidism, which is failure of the testes to descend normally into the scrotum. In contrast, an epispadia is a urethral opening on the dorsal side of the penis. This is much less common than a hypospadia. Remember, those urogenital folds have to come together kind of like a zipper, and it's very easy for a little gap to remain and cause a hypospadia. In contrast, for an epispadia to form, the only way this can happen is if there is abnormal position or formation of the genital tubercle, and this is much less common. And because the genital tubercle is at the top of the external genitalia close to the bladder, this commonly occurs together with bladder exstrophy, where the bladder is located outside of the body. Development of the external genitalia in the male requires dihydrotestosterone. Recall that testosterone can be converted to dihydrotestosterone by the enzyme 5-alpha reductase, and dihydrotestosterone is a much more potent androgen than testosterone. So rarely male children are born with a 5-alpha reductase deficiency, and as a result they will have ambiguous genitalia until puberty. That's because there's not enough dihydrotestosterone around to drive formation of the male external genitalia in development. At puberty, there's usually a rise in testosterone levels, and they may be able to create enough dihydrotestosterone to drive formation of male external genitalia, but at birth they have ambiguous genitalia because they can't form dihydrotestosterone. Now let's talk about external genitalia development in the female. So in the female, the genital tubercle elongates and becomes the clitoris. In the female, the urogenital folds do not fuse, they persist and become the labia minora. In females, the urogenital sinus forms glands, just like in the male, but different glands form in the female. In the female, glands called paraurethral glands of Skene form. These are the female analog to the prostate glands. In addition, the urogenital sinus forms glands called the Bartholin glands. Both of these glands lubricate the vagina. And then in females, the labiosacral swelling develops into the labia majora, not the scrotum. And for this process to occur normally in females, estrogen levels must be higher than androgen levels. And that concludes our module on genital development.